today we're excited to welcome Adrianna Bruni. She's a palliative care physician at the Ottawa Hospital. She went to medical school at the Northern Ontario School of Medicine in Thunder Bay, and then she did her family medicine residency at Western. She did an extra year of training in palliative care at the University of Ottawa, and then since has been working in the Division of Palliative Care at the Ottawa Hospital and the Queensway Carleton Hospital since 2020. So for folks here in Ottawa, hopefully you've heard about the PAL Sale Clinic, but she's one of the founding members of the Palliative Support in Advanced Illness Clinic at the TOH, which provides early outpatient palliative care to patients with end-stage liver disease and end-stage kidney disease. So we're really fortunate to have Adrianna join us tonight. She's actually on maternity leave with her caring for her 9-month-old son. So looking forward to first Christmas for baby. And we're really grateful you could be here with us tonight, Adrianna.
Well, thank you guys very much for joining. So as mentioned, we'll discuss tonight care of LTC residents with end-stage kidney disease. And most of the information that I've learned and the knowledge I've gained about this topic has been from working in the clinic that Val mentioned, so the Palliative Support and Advanced Illnesses Clinic, and some collaboration that we've done with nephrology team. So no conflicts of interest to disclose. I am going to mention a couple of off-label medication usages, as is common in palliative care. And then all of the pictures that I used have Creative Commons licenses. An outline for this evening: we'll review end-stage kidney disease and dialysis. We'll talk about trajectory and survival in end-stage kidney disease, and we'll talk about that for patients who are on dialysis and those who are not on dialysis. We'll talk about symptoms in end-stage kidney disease and strategies for how to manage them, and we'll review some physical and some psychological symptoms. And then we'll end off by talking about end-of-life care in end-stage kidney disease and how to counsel patients and families about what to expect. So I just wanted to start by giving a little bit of context to this topic and the importance of it. So research has demonstrated that patients who are dying from organ failure, like end-stage kidney disease, in comparison to patients who are dying from cancer, they're less likely to receive palliative care. When they do receive palliative care, it tends to be of lower quality, so it tends to start later in the disease trajectory, and it's less intense in terms of the number of days provided. And they also tend to overall have worse understanding of their illness. So overall, that represents an equity issue for this patient population. And so supporting education about this topic is a step towards addressing that inequity. So we'll start by reviewing end-stage kidney disease and dialysis. So kidney disease is very common. 1 in 10 Canadians have kidney disease. The leading cause of kidney failure is diabetes. And then it's associated with significant mortality as well. So in 2018, kidney failure was the 10th leading cause of death in Canada. This is a chart that just reviews the 5 stages of chronic kidney disease. So just as a reminder, stage 4, when the GFR falls below 30, is termed as severe chronic kidney disease. And then stage 5, when the GFR falls below 15, is termed as end-stage kidney disease, and that's when a patient might have to start dialysis. So discussions about whether a patient will eventually go on dialysis do typically start early. Like nephrologists will begin to have those discussions when the GFR is still around 30. But once the GFR drops below 15 with presence of uremic symptoms, or below 6 even with no symptoms, and there's no transplant available or accessible for the patient, then that's the time when the patient and their family have to make a final decision about how they're going to manage their end-stage kidney disease. So some patients will choose to initiate dialysis, and others will say, I never want to be on dialysis, and instead they'll go for a conservative care approach, so conservative kidney management. So for those who do start dialysis, there's a couple of different modalities. So some patients go on hemodialysis, and that can occur at the hospital, usually 3 times per week, or at home in certain situations. Hemodialysis involves being connected to a dialysis machine. Blood is filtered through the machine, removes waste and toxins, and then the clean blood is returned to the bloodstream after that. And then peritoneal dialysis occurs at home. It involves using a cleansing fluid that's called a dialysate, passes through a catheter in the abdomen into the peritoneal cavity, and absorbs waste products from the blood vessels in the peritoneum through diffusion and osmosis. And then the fluid is physically removed and discarded. And so the patient will do that multiple times per day. So trajectory and survival in end-stage kidney disease. So annual mortality for patients on hemodialysis specifically is about 20%. And the median overall survival time on dialysis is only 5 years. So this is important because some patients look at dialysis as being a cure for their kidney disease, but it's not a cure, it's just a temporary treatment. End-stage kidney disease is still a terminal illness that will continue to progress over time despite being on dialysis. And then the other important thing that's relevant, especially for the LTC population, is that survival on dialysis varies substantially depending on the patient's age. So this is a chart from the Ontario Renal Network, and they're looking at 10-year survival in patients who are on dialysis due to diabetes. And you can see that 3-year survival for patients who are less than 50 is over 80%. But for patients who are over 80, it's less than 50%. And then 5-year survival for patients who are less than 50 is still over 70%. But for patients who are over 80, that drops to 30%. So a big difference depending on age. Sometimes as healthcare providers, we're a little bit hesitant to discuss survival in patients with end-stage kidney disease because prognosis is notoriously difficult to predict accurately in this population. But I wanted to point out that there are some useful tools to kind of guide discussions about this. So this particular one is called the Cohen model, and it estimates 6-month mortality for patients who are on hemodialysis, and it uses 5 different variables. So the nephrologist answering no to the surprise question. So would you be surprised if this patient passed away in the next 6 months? They also look at their albumin level, their age, presence or absence of peripheral vascular disease, and then presence or absence of dementia. So I tried it out by responding to these questions in a way that I think would be maybe typical for a patient from LTC who's on dialysis. So answering no to the surprise question, an albumin level of 31, age of 82, no dementia, but presence of peripheral vascular disease. So for a patient that has those criteria, estimated risk of death on hemodialysis at 6 months would be 46.1%, so close to 50%. And so it just kind of gives you an idea, and it can help you frame a discussion. You can use the palliative care concept of hoping for the best, like we hope this patient is still surviving and thriving 6 months from now, but also planning for the worst. So having discussions about their future wishes in case that changes, given that the risk of that happening based on the model and these numbers is certainly present. So another discussion you might have to have with patients at the LTC would be regarding discontinuation of dialysis. So discontinuation of dialysis would happen for 2 possible reasons. One would be that the patient isn't really tolerating dialysis anymore. When they're getting dialysis, maybe their blood pressure is dropping considerably. So at that point, the nephrology team might say to the patient, we can no longer safely offer dialysis at this point, and we need to stop it. But alternatively, some patients might make that decision for themselves. So a patient might start finding it too burdensome to attend dialysis, or they might start developing intolerable symptoms or side effects from dialysis, like cramping, or they might have experienced a change in their quality of life, and they may not want to continue doing something so active to prolong their life based on that change. So in those situations, a patient might express a desire to stop attending dialysis. So if you're the healthcare provider for the patient in that scenario, the first thing you would want to do is make sure that there's no potentially reversible issue that's prompting that decision. So making sure there's no like undiagnosed depression or uncontrolled pain that's motivating the patient to want to stop dialysis. Once you've addressed anything like that, then you want to confirm with the patient or the substitute decision maker that it's certainly their decision if they want to stop dialysis and they're not going to be forced to continue it, and you can support them in that. However, it's important that you make sure they clearly understand the consequence to not attending dialysis, which is almost definitely death in a short period of time. So to help with that type of counseling, most patients who stop dialysis end up dying within short days to short weeks. The literature generally shows an average of about 1 week. But the volume of urine that a patient produces does have an impact. So patients who are still producing urine might tend to have a slightly longer prognosis after stopping dialysis, and patients who don't produce any more urine tend to have a bit of a shorter prognosis after stopping. The other important thing is that because dialysis stabilizes the electrolyte levels, patients who stop dialysis are going to be at risk for sudden cardiac death due to electrolyte abnormalities like hyperkalemia. So it's important to counsel patients and families on that as well. And then on the other end of the spectrum, some patients end up living much longer than that kind of 1 week average. I've seen patients live for a month after stopping dialysis a number of times, and I have talked to some of the nephrologists who have seen patients live for many months in more rare circumstances. But so when you're counseling patients and families, you kind of want to prepare them for that range of possibilities, recognizing that approximately 1 week would be the average. And there was actually just a study published this year in 2024 about prognostication after dialysis withdrawal. So they did a retrospective cohort study of patients who discontinued hemodialysis and peritoneal dialysis. This was in New Zealand and Australia. And they found that median survival time was 6 days after stopping hemodialysis and 4 days after stopping peritoneal dialysis. And they also were able to confirm that for hemodialysis, patients who were still producing urine when they chose to stop dialysis did survive for significantly longer than those who weren't producing any urine. So those are just some numbers to kind of guide those discussions with patients and families. But what about counseling patients with end-stage kidney disease who never wanted to start dialysis in the first place? So those who chose that conservative kidney management instead. What I've found is that it's actually even more challenging to counsel them about prognosis. So this was a narrative review that looked at survival of patients who were over age 65 who had advanced CKD that was managed without dialysis. So they found a large range of median survival estimates, range from 1 to 45 months, with 1-year survival rates of 29 to 82%. So of course, these large ranges make it really tough to accurately prepare patients for what to expect going forward. They did find that generally patients who chose dialysis lived longer than patients who chose conservative kidney management. But something relevant to the LTC population is that actually, if they only looked at patients who were 80 years or older, or patients who had high comorbidity burden and poor functional status, then there was no longer a difference in the survival between those who went on dialysis and those who chose conservative kidney management. So this is one of the graphs from their paper that compares median survival in months in the different studies that they looked at. And so again, you can see there's a really large range, but it's kind of helpful to look at these two, the ones in orange. These two studies looked at survival in months after the GFR dropped to 10 or below. And so in that case, once the GFR got to that level, survival was a little bit more consistently short. So 12 months in one study and 6 months in the other. But for me, the general message that I take from the graph is that if you're counseling a patient who's chosen conservative kidney management, you can kind of tell them that the range of survival goes from a few months to a few years. And so the information that's going to be more helpful to us in terms of helping them understand what to expect over time is going to be looking at that change over time. So change in their symptoms and their clinical status, and then change in their functional status as well. And if those things are changing rapidly, of course, we'll anticipate a shorter prognosis. And if those things are having more stability, then we'll anticipate a longer prognosis. This is another graph from their study. So this one, they compared 1-year survival rates between patients who chose CKM, so conservative kidney management, versus those that chose dialysis. So if we just look at one of the specific ones, so the study by Kwok in 2016, they found that 1-year survival for patients who chose conservative kidney management was 40%, while it was up to 79% for patients who chose dialysis. But similar to what I mentioned a couple slides back, when they did their subgroup analyses and they just looked at patients who were 85 years or older and had high comorbidity scores and poor functional status, again, there was no longer a difference in the 1-year survival rates for patients who chose CKM versus dialysis. Okay, so we'll move on to discussing the symptom burden in patients with kidney disease. So first of all, research has confirmed that symptom burden in patients with kidney disease is quite significant. So there was one study done by Jaume et al. In 2019, and they looked at 3 symptoms in particular, so pain, fatigue, and depression. And they found that the burden of those 3 symptoms was similar in patients who had kidney disease compared to patients who had gastrointestinal cancer, so comparable to patients with malignancy. And then there was a global meta-analysis that was published in 2022. So they looked at almost 200,000 patients in 62 different countries and concluded that patients with chronic kidney disease do report a wide range of common symptoms and severe symptoms. And they also found that quality of life is significantly lower in patients who have kidney disease compared to patients who don't have kidney disease, and also that it's particularly bad in patients who are on dialysis. So to look at that a little further, there's a study here by Rhee et al. In 2020, and they were looking at prevalence of uremic symptoms, specifically in patients on dialysis. And what they did was compare 2 previously published studies. So the CHOICE study, which looked at prevalence of uremic symptoms between 1995 and 1998. And then the LUCID study looked at prevalence of uremic symptoms between 2011 and 2017. So they found that dialysis patients had really high prevalence of these uremic symptoms, so fatigue, anorexia, pruritus, sleepiness, nausea, vomiting, difficulty concentrating, and pain. But they also found that the prevalence remained high in the years between the 2 studies. So even though there's 15 years between the CHOICE and the LUCID study, the prevalence in the LUCID study was still really high. So there hadn't been a big difference in that despite so many years passing. They also found that over 80% of patients in both studies had 3 or more of the uremic symptoms, and they found that over 50% of patients had more than 5 of the uremic symptoms. So again, symptom burden of patients with kidney disease is really significant. So let's focus on pain specifically. The prevalence of pain in patients with end-stage kidney disease is reported to be upwards of 60 to 70%. And multiple studies on this group of patients suggest that pain tends to be undertreated. And this is important because, especially for those patients who are on dialysis, uncontrolled pain might result in them shortening some of their treatments or missing some of their treatments, or like the example I mentioned, they might even be motivated to discontinue dialysis due to uncontrolled pain. So it can really have a negative impact on their life expectancy and survival. So for managing pain, looking at some non-opioids first, acetaminophen is metabolized extensively in the liver, and there's no significant changes observed in patients with kidney failure. So this is kind of the first-line analgesic for this group of patients. You have to be more cautious with NSAIDs in this population because NSAIDs will cause risk of increased bleeding, cardiovascular events, and then also reduction in GFR. So if you have a patient who's got kidney disease but still has some residual kidney function, they produce urine, and you give them an oral NSAID, it can actually cause a severe and irreversible reduction in the GFR. So that can have severe consequences for the patient. You can use topical NSAIDs though, so something like a diclofenac cream could provide pain relief without having the systemic adverse events. And then the other thing to think about is if you have a patient who has no residual kidney function, so a patient who's on dialysis already and doesn't produce urine, then you might use an oral NSAID, a short course of one for pain, because you don't have to worry about that irreversible reduction in GFR if they already have no residual kidney function. So that's something that we do sometimes after chatting with the nephrology team. For opioids in end-stage kidney disease, there's a lot of kind of nuances to using them that I've found out about over time. So patients with kidney disease are going to be at increased risk for adverse effects from opioids, and that's due to reduced elimination and increased accumulation of the parent opioid and then also the active metabolites. And so overall, patients who have kidney disease have a really narrow therapeutic window between the dose of opioid that you would need to achieve pain control and then the dose of opioid that's going to end up causing toxicity. So it's a tricky balance of kind of risk and benefit in this patient population. So I wanted to review appropriate versus inappropriate opioids in kidney disease. And what I've seen is that different healthcare providers will kind of have different opinions on this, some finding that they don't seem to notice any difference depending on which opioid they're using in patients with kidney disease, and others are stricter about which ones they use. So there's definitely different practice styles in that way. For myself, I base my practice on the Ontario Renal Network guidelines, and then also a couple of summary articles that were published by Dr. Sarah Davison. She's a nephrologist and palliative care doctor and a researcher in Alberta, and she's published a number of guidelines about this group of patients. So that's what I go with, but definitely I have seen some variation in people's thoughts about this. So although the specifics vary by resource, generally opioids that are considered appropriate in end-stage kidney disease, so patients with that GFR below 30 or below 15, would be fentanyl, methadone, hydromorphone, and then also buprenorphine. And then on the other hand, tramadol, morphine, and codeine are generally recommended to avoid or be extremely cautious with. So to explore those in a little bit more detail, the two inappropriate weak opioids in kidney disease would be codeine and tramadol. So codeine is metabolized to the active metabolite morphine. So just 5 to 10% of codeine is metabolized to morphine. But the effectiveness of codeine for any given person is dependent on the number of copies they have of this cytochrome P2D6 enzyme. So some people are ultra rapid metabolizers and they can get a small dose of codeine and still develop respiratory depression. And other people are poor metabolizers and they could get a large dose and still have no pain control whatsoever. So it's a really unpredictable effect. And then codeine and morphine both accumulate in kidney disease and can cause toxicity. So because of the possibility of toxicity and then also that unpredictable effect, codeine's not recommended in this population. And then for tramadol, tramadol has a dual action. So it's an opioid agonist, but then it also is a serotonin and norepinephrine reuptake inhibitor, similar to some of the antidepressant medications. So because of that, and then the fact that many patients with kidney disease are already on a lot of different medications, if you give tramadol to one of these patients, it's possible that it could interact with some of those other medications and cause something serious like serotonin syndrome. The other thing is that tramadol can decrease the seizure threshold as well. So there's some risks with this medication, especially in a population that's already baseline on the frail side and tend to have a number of comorbidities as well. And then inappropriate strong opioids in end-stage kidney disease, generally morphine is listed as being inappropriate for a patient with a GFR below 30. So morphine is metabolized to M3G and M6G. M3G has no analgesic effect, but it has a potent neuroexcitatory effect, so it can cause toxicity. And then M6G is the analgesic. But both of them are active metabolites and can cause toxicity. And both of them accumulate in patients with kidney disease. M6G is dialyzed, but even when it is, it diffuses out of the CNS very slowly, so a higher risk of toxicity there as well. So the opioid that's generally seen as most appropriate in end-stage kidney disease, and the first-line opioid recommended by the Ontario Renal Network in this population would be hydromorphone. So hydromorphone is metabolized to H3G, so similar to the M3G in morphine. It doesn't have analgesic effect, but it can cause some neuroexcitatory effects. The half-life of hydromorphone is not changed with kidney disease, but the half-life of H3G, the metabolite, is prolonged. But the good thing is that H3G is effectively removed during dialysis. So in general, like we definitely have patients in our clinic and on dialysis who are on morphine and they do fine with it and they don't have major side effects. But overall, hydromorphone is considered to be the safer choice in this group of patients. So I tend to go with that one first line and then only use morphine if necessary. Other appropriate opioids in kidney disease, so fentanyl is considered an appropriate opioid for this group of patients because the metabolites of fentanyl are inactive, which means that when fentanyl is metabolized, the metabolites have no further effect on the body, whereas an active metabolite will have another effect on the body. So the inactive metabolites are less likely to cause any toxicity. But the caveat with fentanyl is that it's such a potent opioid that it's only for patients who are already opioid tolerant. You'd never want to start it in an opioid naive patient, so that kind of limits its use in this population. And then methadone is also considered an appropriate opioid in kidney disease. It's got dual action as well, so opioid agonist and then NMDA receptor antagonist, which seemingly makes it a good choice for neuropathic pain. And then like fentanyl, methadone has inactive metabolites, so less likely to cause toxicity. And the other interesting thing with methadone is it's excreted in the feces and in the urine, but in a patient who doesn't have urine production anymore, so somebody without any residual kidney function, more of it would be excreted in the feces, so there's like a compensatory mechanism there. The caveats or the issues with using methadone in this population are that there are many drug interactions with methadone. And like I was mentioning, patients with kidney disease do tend to have a number of comorbidities, so they may already be on a long list of medications. You have to be quite cautious with the interactions. And then the other thing is that methadone could predispose someone to QT prolongation, and that's already a possible issue for these patients. So you have to be cautious with those things, but it can be a good choice. And then buprenorphine has two major metabolites, so B3G and norbuprenorphine, and they're mostly excreted fecally, only a small percentage excreted in the urine. So I think this one has like the potential to be a great choice for these patients, but I find that use of this tends to be limited. And I think the main barriers are issues with coverage, so cost, and then also lack of prescriber experience, because I've found that even doctors who've done the extra year of training in palliative care, like I did, still don't have a lot of experience using this medication. So people just aren't as comfortable with it, but it might be one that we see used in this population more in the future. And this is a summary table that lists the opioids, and then it's got the inactive metabolites, which again have no further effect on the body, and then the active metabolites, which can cause toxicity. So you can see that I put the arrows in blue. Fentanyl and methadone are the only two that have no active metabolites at all. And that's why they're felt to be less likely to cause toxicity in patients with kidney disease. But despite that, hydromorphone is still considered the first-line opioid in kidney disease, even though it has that active metabolite H3G that could cause toxicity. And that's because of those kind of caveats, those issues that I mentioned with fentanyl and methadone. So for fentanyl, just being such a potent opioid that you'd that you'd only want to start it in a patient with opioid tolerance. And then for methadone, having those concerns with drug interactions and then QT prolongation. So this is kind of my bottom line from the reading that I've done. My practice is that when a patient with a GFR below 30 requires opioids, I would typically avoid codeine, tramadol, and morphine. If their GFR is above 30, then you don't have to worry about that. I would use hydromorphone first line for patients with GFR below 30, but I would dose it less frequently, and I'd still monitor for toxicity because it does have that H3G metabolite that could cause neuroexcitation. And then if the patient does develop toxicity on hydromorphone, I would think about rotating to fentanyl or methadone if the patient is on sufficient doses to make that safe and reasonable to do. But if the patient was on just a really low dose of hydromorphone and developed toxicity, then I would rotate to morphine. I would just be cautious with it, and I would monitor closely for any further signs of toxicity or worsening toxicity. And then I just reiterated here, buprenorphine, it might be a good option in the future, but I think it's just limited by cost and prescriber experience at the moment. So you see a lot of patients with end-stage kidney disease who have neuropathic pain specifically, so that pain with that shooting, burning, radiating quality. And for a lot of them, it's because they have underlying diabetes, and that causes diabetic neuropathy. So this is a common issue that we see. So there's a few different medications that can be considered for this. First line for neuropathic pain in patients with end-stage kidney disease is actually the gabapentinoids. So gabapentinoids like pregabalin and gabapentin, they're almost exclusively cleared by the kidneys. So you really have to dose reduce them quite a bit to make them safe for this population. So for patients with GFR below 15, so end-stage kidney disease, the max dose of pregabalin is 75 milligrams per day, and for gabapentin, 300 per day. So it's quite a bit lower than what you'd use for someone without kidney issues. And even at those reduced doses, sometimes you still see adverse effects, but you just have to monitor for them closely because these medications can definitely work well in this population. And then the other thing that I've learned is that over 50% of the gabapentinoids are removed during dialysis. So if you have a patient who's on dialysis and receiving gabapentinoids, you want to try to give them their dose after dialysis or offer a supplemental dose when they finish dialysis if needed. And then another option would be an SNRI, so like duloxetine. You can use 30 milligrams per day. This one is particularly a good choice if the patient also has a mood disorder, because you might be able to treat the mood disorder and the pain kind of with the same medication. And then also, sometimes I'll try using duloxetine if I have a patient who's more elderly and maybe didn't tolerate gabapentinoids, because sometimes even at those low doses, a patient will get side effects. So duloxetine is one that you can try instead. And then you can also consider tricyclic antidepressants. They can work well in neuropathic pain, and even if you add them on to gabapentinoids, they can have a good effect. But they do tend to be a little bit less well tolerated in this population because many of these patients have already some baseline frailty, so the anticholinergic side effects can be a problem. So you have to just be cautious, like with all the medications, you need to be more cautious in this population. So another symptom that we see commonly in this population would be pruritus or itchiness. If you have a patient who's got end-stage kidney disease and is experiencing pruritus, you want to kind of think about what the underlying cause is. Sometimes it could be related to the kidney disease and sometimes not. So if you have a patient who's on dialysis specifically, you can speak to their nephrologist because sometimes the itch is actually from inadequate dialysis or having a reaction to the dialyzer. And then there's a few different electrolyte abnormalities that can contribute to itchiness as well. If kind of those things have been ruled out, you can also think about whether they actually have an itch that's not related to their kidney disease at all. So common things like dry skin, infestations, allergies, contact dermatitis. Some blood cancers can cause itchiness, and then liver disease as well. So you can think about those potential causes. If you have to treat the symptom of pruritus in a patient with kidney disease, you can try a topical cream, especially for localized itch. So if it's a small area, you can try capsaicin cream or some mix of menthol, camphor, and hydrocortisone. For myself, I usually would start menthol 0.5% in a Glaxol-based cream and then kind of add in the other ingredients as needed and apply it twice or 3 times a day as needed. But if it's more of kind of a generalized itch and treating it topically doesn't really make sense, first line again would be the gabapentinoids. So these can be used off-label for itch in this patient population. And again, you just have to be cautious with the dosing and stick to those maximum doses in patients with GFR below 15. But I've definitely seen them be pretty effective for itch in a number of patients. If the gabapentinoids aren't effective, you can consider an oral antihistamine like diphenhydramine or hydroxyzine, but just monitoring for the side effect of sedation with those. If those aren't effective, there's some evidence that SSRIs like sertraline or paroxetine might help with itch, and then also mirtazapine. There's not very good evidence for this, but it's possible that it could help. So especially, again, if I had a patient who had itchiness and a mood disorder, I might try sertraline or paroxetine as first line. I find it's always beneficial, especially in these patients who are already on a lot of medications, if you can ever find a way to target kind of 2 symptoms with 1 medication. And then mirtazapine is something to think about, especially if the itch is worse at night, because it also can help with insomnia. Severe cases, according to the algorithm on the Ontario Renal Network, you can refer to dermatology for UVB light therapy, but I'm not sure how accessible that would be in the real world. And then I just put a note of this one. So difelikefalin, it's a newer medication that just got approved by Health Canada fairly recently for treating itch in adult hemodialysis patients. But it's an IV medication that they give during hemodialysis. So you would see the nephrologist prescribing that one. But I just mentioned it because I've seen it on the medication list for a few patients recently. And then the other common symptom that you can see in these patients would be restless leg syndrome, or RLS. So just a reminder, restless leg syndrome being that unpleasant sensation in your legs, kind of having that irresistible urge to move your legs when you're lying still. So similar to with itch, you want to think about potential causes for this first. So considering mimic disorders, so things that kind of present as RLS but aren't. So one thing would be local leg pathology like peripheral vascular disease. The other thing is to think about drug-induced RLS. So in palliative care, we use a lot of dopamine antagonist medications, so like haloperidol, metoclopramide, or methotrimeprazine. And so any dopamine antagonist can cause the extrapyramidal symptoms like akathisia, that feeling of restlessness and needing to move. So if you have a patient with RLS who's on a dopamine antagonist, you can consider titrating that down or holding it and see if it helps. And then antidepressants can also contribute to restless leg syndrome, and mirtazapine is one that especially can. So just keep that in mind for patients who are taking that medication. And then iron deficiency can contribute as well. So you might even think about checking a ferritin for patients if this symptom is really bothering them. To treat RLS, if you've kind of addressed those previous things, the first-line treatment used to be levodopa, but they found that there was risk of augmentation with this, meaning that you give the levodopa to try to treat the RLS, but it ends up paradoxically making it worse. So I've seen that the nephrologists lately seem to be using ropinirole or pramipexole more commonly because those ones don't have that risk of augmentation. But if you have a patient who has RLS, but also has diabetic neuropathy or just neuropathic pain in general, then it's reasonable to try, again, a gabapentinoid instead. So abiding by those maximum doses, but gabapentin or pregabalin can help with RLS in addition to neuropathy. So if both symptoms are present, I would consider that. Okay, and then I wanted to just review psychological distress in end-stage kidney disease as well, because this is common too. So there was a meta-analysis published in 2013 that looked at prevalence of depression in kidney disease. And what they found was that almost a quarter of patients had depression based on interview scores, and almost 40% of patients had depression based on their self-rating scales. So it was quite prevalent. There was a similar study, a meta-analysis published looking at anxiety symptoms in patients with chronic kidney disease, and they found prevalence of anxiety disorders was 19%, but the prevalence of just elevated anxiety symptoms in general was 43%. So both depression and anxiety are common in this group of patients. There have been a couple Cochrane reviews published looking at treatment for these things. So this one in 2019 looked at psychosocial interventions to treat depression in patients with ESKD on dialysis. They found moderate certainty evidence that CBT, exercise, and relaxation techniques probably help, but they found very low certainty evidence for things like spiritual practices, acupressure, telephone support, and meditation. So definitely you can recommend things like CBT. I think one barrier to that in the dialysis population is that they're already quite burdened by their visits to the hospital for dialysis. So CBT can be an additional time-consuming medical visit, so that can be a bit of a challenge. And then there's another Cochrane review, 2016, that looked at the pharmacotherapy for depression, so antidepressants in adults with ESKD on dialysis. And they actually found very minimal evidence. So they said evidence for antidepressants in this population is very sparse, and data were generally inconclusive to the point that they couldn't actually make any specific recommendations. So hopefully another one will be published eventually with some more specific ideas, but other resources suggest that SSRIs are generally recommended first line to treat depression or anxiety in patients with kidney disease. I would consider sertraline because sertraline has no dosage adjustment requirement for patients with kidney disease, even patients on dialysis. The caveats are that there's been no head-to-head trials comparing efficacy of sertraline versus other agents for patients with end-stage kidney disease. And then there was even one randomized control trial published in 2017 that looked at patients with CKD, and it showed no significant difference between sertraline and placebo. So the evidence isn't great, but I think based on the fact that you don't need to dose adjust it, it's at least a safe one to try in the first place, and there is good evidence for it in other populations. And then the other recommendation that I came across was to avoid citalopram and escitalopram. So the idea being that those two SSRIs can cause QT prolongation, and patients on dialysis are already at an increased risk of adverse cardiac events. And in fact, there was even a study published that looked at that exactly. So in 2019, this study compared cardiac safety of SSRIs in people on dialysis. They actually looked at 65,000 hemodialysis patients, and they found that those who were receiving SSRIs with a higher potential to prolong QT, so citalopram and escitalopram, had a higher risk of sudden cardiac death than compared to those who were receiving SSRIs with lower potential to prolong QT. It definitely had some limitations, like they didn't look at baseline QT interval, but still it's kind of enough to make you think and maybe try something like sertraline that doesn't affect the QT as much as opposed to those ones, and at least see if it works to be on the safe side. If you're looking for an alternative to sertraline, you can try another SSRI like fluoxetine or paroxetine, because they don't have as much of an impact on the QT either. You can try an SNRI. So we mentioned duloxetine already in the context of treating neuropathic pain. So again, especially if they have both of those symptoms, that's a good consideration. Or venlafaxine, that one can be used as well, but there are some dosage adjustments that you need to abide by. And then mirtazapine, we mentioned in the context of maybe treating itch, especially in those who had itch at night. So mirtazapine can help with mood and can also help with sleep. So you can start with 7.5 milligrams daily and then kind of titrate it slowly upwards while monitoring for adverse events. So finally, I just wanted to review again end-of-life care in end-stage kidney disease. So when you're counseling patients at the end of life and their families. So we kind of mentioned prognosis already, but just to kind of review that, if a patient who's on dialysis stops it, general prognosis would be approximately 1 week with that risk of sudden death from electrolyte abnormalities as well. And remember that paper about 6 days in hemodialysis, about 4 days in peritoneal dialysis. So I think counseling about approximately 1 week is reasonable. And then for patients who've chosen that conservative kidney management, very difficult to make a guess on prognosis early on. You're going to want to just monitor for clinical and functional changes over time to get an idea of when they're eventually progressing towards end of life. And some of these patients who continue to follow with their nephrologist do still get their creatinine and GFR checked every number of months, and that gives a little bit of an idea as well. In terms of the main symptoms to prepare a patient and their family for eventual end of life, for those either stopping dialysis or progressing while on conservative care, you want to talk to them about somnolence, so increased fatigue, spending more and more time in bed, delirium, so agitation and confusion related to underlying uremia, and then dyspnea. So especially when dialysis is stopped, you can have some fluid accumulation that can contribute to that. So you want to be prepared for all of those symptoms and how to manage them at the LTC. And then one particular note about this group of patients is that as a person providing palliative care to these patients, you might be challenged to distinguish uremic encephalopathy from opioid-induced neurotoxicity, because both of those things look very similar. They'll cause sedation, hallucinations, and even the myoclonic jerking. So if you have a patient dying of kidney disease and they were started on opioids and you're noticing those things, you can always try an opioid rotation just to see if it will help. But it's certainly possible that it won't get better because it's just the underlying uremic encephalopathy. And in that case, you just want to treat it with your standard end-of-life medications for delirium, like benzodiazepines, methotrexate, or phenobarbital. So I have a number of references here that we can distribute afterwards, but that's the end of my presentation. So thank you so much for your attention and your time.